Let's hear the situational report on the ground on health, mobility, also just mentioned by Sen Aimee, health, mobility, and public safety. Ito naman po from Amy Santos for UNFPA. Amy, you have the floor.
Salamat, Senator. Magandang umaga po to our honorable senators, the members and staff of the Senate Committee on Women, Children, Family Relations, and Gender Equality. I've been asked to speak on the gendered impacts of the pandemic, and we are grateful to Senator Riz Ontiveros for this invitation, and I'm very honored to speak here on behalf of the United Nations Population Fund. The UNFPA is a strong partner of the Philippine government and united in achieving the 3 transformative goals that are to reaching sustainable development by 2030. We are the UN agency committed to achieving 3 zeros: 0 unmet need for family planning, 0 maternal deaths, and 0 violence and harmful practices against women and girls. Maraming salamat kay Joanna who's helping me staff my slides. If I could go now to slide 4. In this inquiry, UNFPA would like to provide testimony based on 2 studies that UNFPA initiated. The Gender and Inclusion Assessment that Ms. Pura has already explained quite in depth, and a mathematical modeling study that we commissioned the UP Population Institute to do. Now, first, the Gender and Inclusion Assessment study really tried to understand more qualitatively and clearly how women and men in marginalized communities are experiencing the pandemic differently, what their needs are, what the barriers, the challenges, what the coping strategies and capacities that they're experiencing because of the prescribed gender roles and the societal imbalance of power between women and girls, women and boys. And the second, the UPPI study, we try to project and calculate how the pandemic may affect the status and well-being of women and girls with regards to issues of health and safety. Now, although this is a global pandemic, we know that the Philippines approached it in a very specific manner, as Senator Aimee has already alluded to. We had the closure of mass transit. We had the assignment of a quarantine pass that allowed you to travel outside to secure food or medicine. There were security checkpoints along the perimeters of cities and provinces, an 8 p.m. curfew, and there were arrests if you violated any of these measures. And even as these restrictions were imposed on all Filipinos, qualitative and quantitative evidence show that they affected women and men differently. And even among women, different groups of vulnerable women suffered the worst consequences of these measures. Next slide. The restrictions on mobility, in particular, were designed to slow down and prevent the infection of COVID-19. Yet the unintended consequences of these restrictions may have helped reinforce gender discrimination and inequity, particularly in municipalities where community leaders default to gender stereotypes. So, for example, a number of respondents of our Gender and Inclusion Assessment reported that when quarantine passes were exclusively put in the male husband's name because they're head of households, it disproportionately curtailed women's movements, making them dependent on their husbands for food, basic goods, or medicines. And at the same time, another set of respondents reported that the quarantine passes in their municipalities were exclusively named after the women because they were seen as the lone homemaker or the natural caregiver in the family. And here, the women respondents feel the extraordinary weight of care work because mass transit was closed down and they were heavily dependent on that. So in both these reports, the women respondents expressed either being immobilized or carrying the disproportionate burden of their family's welfare. And this is only one example. So when quarantine measures do not take into consideration the context and the circumstances of diverse families, of women and men who need to determine for themselves what they need and how to share the workload, they unintentionally narrow families' choices and may inadvertently cause harm by imposing a one-size-fits-all when not all people or all families are the same. Households do not have the same number of members, they do not have the same degree of health, capacities, or assets. So in this instance, making the decision for people and their families without consideration of their individual context or needs, they default to gender stereotypes, and we reinforce gender inequity and widen the gender gap. Next slide, please. And when we examined this further, we saw that across 11 categories of vulnerable people, people with disabilities were particularly vulnerable. No? The additional stress and depression that overwhelming care work brought with them. A significant number of respondents who were women with disabilities reported more stress and depression than women without disabilities. And at the same time, we saw a very pronounced difference between men with disabilities compared to men without disabilities. And here we see bias actually harming the men. Although we can only speculate why there is such a significant difference between men with disabilities and men without disabilities, we think that it's reasonable to suspect that men do not expect to do unpaid care work. And when they're forced by circumstances to do housework, men with disabilities suffer more mental health issues as internalized limited competencies are heightened. These are probably some of the more difficult and painful interviews that we did in the GIA. There were stories of suicidal ideation, of actually reaching the end of their rope. The Filipinos' very much famous, very lauded resilience beginning to fray. And we know from the National Center for Mental Health that calls to the hotline have doubled for the same period as last year. But we need more data on the potential gendered nature of these calls because this can help sharpen our response and our resources. Next slide, please. Now, in a health crisis, especially in a global pandemic of this scale, access to basic health services is crucial. Among vulnerable populations, you will see that red line. That represents the average baseline of respondents who say that they have continued access to health services. So slightly above that average, we see women, 4P recipients, and rural respondents more likely to report that they have continued access to health services. This might be an indication of how existing protections are holding traction and extending significant health benefits to those groups. However, farther below the average are several marginalized communities who report experiencing a disruption in their access to health services, which we know are vital in a global pandemic. We hear men, LGBT, urban poor, internally displaced people, and indigenous people respondents who are saying that they suffer a significant disruption in health services. And this differential access of respondents in vulnerable communities mean we are leaving different groups of people behind systematically more than others. Next slide, please. Now, a specific health concern that targets women and LGBT respondents in our study specifically indicated access to sexual reproductive health and rights services. Next slide, please. And they have cause to worry. The results of the UPPI estimation model show that the reduction of services because of the disruption in mobility and transportation due to the induced community quarantine measures will lead to a 26% increase in maternal deaths. There will be 60 additional maternal deaths for every month of the community quarantine. An estimated 666 additional deaths if such measures were to continue until the end of the year. Next slide, please. The same study also showed that there's a substantial increase in the number of unintended pregnancies, 41.5%, and the number of women with unmet need for family planning, 67%, among women of reproductive age. If the community quarantine will continue until the end of the year, the family planning service reduction is estimated to result in an additional 751,000 unintended births and more than 2 million women with unmet need for family planning. This also demonstrates an increase in the percentage of unintended pregnancies for adolescents at 22% and at 32%. These numbers are an epidemic in and of itself. Next slide, please. And if we put this into perspective, this translates into a reduction in the number of Filipinos using modern contraceptives under quarantine conditions. What was already a low baseline rate, one of the lowest in the ASEAN region, has become even lower. Next slide, please. And we also heard from women respondents who were concerned about their access to contraceptives, prenatal services, and medical treatment for their babies, with 2 out of 5 women saying they had limited access to contraceptives. And LGBT respondents similarly expressed a concern regarding their limited access to contraceptive commodities and HIV/AIDS services. 1 out of 2 LGBT respondents expressed that concern. Next slide, please. And as Ms. Pura has already mentioned, young people will bear the worst brunt of this shortage in supplies and services. 18,000 more teenagers may get pregnant because of quarantine-induced service reduction. Next slide, please. And Ms. Pura talked at length about GBV during the quarantine. I'd just like to add a few more slides to show how dire the situation is. We already have multiple media reports of escalating incidents of intimate partner violence, of the growing numbers of child marriages as families cannot afford to feed their families and their daughters, and the alarming increase in the exposure to online sexual exploitation and abuse, as well as the unconscionable demands for sex for passage through security checkpoints. Next slide, please. But in the UPPI projections, we can see that the COVID-19 induced community quarantine will lead to an additional 144,000 currently married women aged 15 to 49 experiencing physical or sexual violence by their intimate partners in this year alone. The study has already shown that a total of 733 currently married women are estimated to experience physical violence by their partners, and 308,000 currently married women estimated to experience sexual violence by their husband or partners. And so we know that this is an epidemic within an epidemic. Next slide, please. And despite the higher incidence, we also saw in our study that the people most likely to be affected by intimate partner violence, the women respondents, reported that they're less likely to report GBV to the police. And among women, it's internally displaced women who are less likely to disclose and seek help from mandated duty bearers. Next slide, please. And so what are humanitarian groups doing in response? An inventory of gendered impacts must also be able to see the emergence of the interventions, the projects, and the programming that is rising to address the material problems and felt issues of constituencies that we work with. In the gender and GBV sector, organizations and agencies are ensuring that we have alternative reporting and monitoring portals. If people cannot go in person to the barangay VAUSI desk, they are now looking for remote modalities to do that. And then we're also ensuring that GBV services along the referral pathway are working, are not being disrupted or discontinued. And so helping capacitate new municipal social workers and hospital-based women children protection units. Next slide, please. At the minimum, we need to ensure that essential sexual reproductive health rights services continue and that the service delivery system is adapting to the quarantine conditions and providing workarounds because people are still having sex, women are still having babies, pregnant women are still in danger of dying during childbirth. The UNFPA has been working with women child protection units in relocating themselves outside the emergency room areas of hospitals because women are afraid to go near them for fear of infection. And so we need to rehabilitate, we need to refurbish, we need to redesign in some of the ways we're providing these services. Next slide, please. In response to the increased rates of GBV, we have comprehensive responses from groups who have established alternative reporting portals so that you can bypass the dysfunctional hotlines and the VAUSI desks, including a voice-activated mobile app that will actually allow GBV survivors to text their preferred GBV service provider when she needs help and to GPS the nearby shelter or WCPU so that they can go to the nearest agency. And the Philippine Mental Health Association is providing free telecounseling services, and we're seeing youth groups who are innovating solutions to the issue of online sexual exploitation and abuse. Next slide, please. And we're seeing in particular that cash-based solutions have very successful gendered interventions in addressing urgent health, protection, and work needs of women and girls who are almost always invisible, no? And almost always left out of the big programs that are being done by their local governments. And so here we see that they're very tailored to their individual needs and capacities. Conditional and unconditional cash grants can provide both flexibility and incentive to specific needs that are otherwise ignored or deprioritized. Next slide, please. So in summary, what we're hearing from the field as well is that throughout this pandemic, we need to do 5 things. We need to, 1, make sure that prevention efforts and services to respond to violence against women as well as sexual reproductive health needs are integrated deeply into COVID-19 response plans. They need to be mandated and required. We need to, secondly, maintain a minimum standard of health services for life-saving services and information that women and girls rely on. 3, we need to emphasize that women and girls who are already finding themselves in humanitarian and fragile contexts and are experiencing compounding crises are particularly given emphasis and support. 4, what we measure matters. What we count is what we see. So we need to prioritize the collection of accurate and complete age and sex disaggregated data in communities that we know are particularly marginalized and vulnerable. And we need to hold ourselves accountable to that data. And 5th, we need to connect the women and girls who in this pandemic are particularly socially isolated from one another. So we need to connect them digitally or through offline modalities that gives them continuous information about conditions on the ground, information about services that they can access, and how else to provide resources to them. So women and girls are experiencing this pandemic in different ways. We need to pay attention to these differences. They are less mobile, they're less free to move to address their needs, they're less safer, they're at higher risk for GBV, and they're at greater risk of becoming unintendedly pregnant or dying in childbirth. If we do not get essential sexual reproductive health rights and GBV services operational and accessible, we fail to serve vulnerable women and girls who are experiencing multiple pandemics right now. And there's never before a humanitarian crisis that has visited the whole of the Philippines. So understandably, an archipelago of diverse regional contexts will see different outcomes and impacts. And yet our overarching observation is that not one region will be spared by the reduction in health and protection services. And if we do not address them right now, the injuries and the invisible wounds that are felt by vulnerable women and girls will be there for years to come. We are extremely grateful for this invaluable opportunity to provide testimony in support of vulnerable women and girls. So thank you very much, Senator Risa Ontiveros and all the senators on the committee.
Thank you very much also, Amy, no? At saka sa UNFPA. I think what we're seeing here, beginning with the first report, moving into the second one, and then moving into our third one, ay pakumplika yung nakikita nating fabric. We're trying to pull the strands apart to see more clearly the important details, the epidemic within the epidemic, or actually epidemics within the epidemic na sinabi ni Amy, multiple pandemics, so that also moving forward, lalo na dun sa scenarios na pinresent niya, that if the quarantine or quarantines continue as they are till the end of the year, such and such are the dire scenarios, and therefore what interventions can and should we actually put in place, especially if mahabi natin yung iba't ibang strands na ito into more effective and enabling, empowering response mechanisms and systems with high participation and leadership by women and girls.